good afternoon, good evening from wherever you are. What an interesting way to have been introduced. I'm still absorbing it. Thank you so much. I would just like to start from your question, which looks like a central question before us. How do we ensure that the 2026 to 2031 Global AIDS Strategy that is at the high level meeting political declaration discussions at the moment anchor itself genuinely in community leadership? I believe the answer lies in placing self-care at the core of our interventions framework. This approach, as you rightfully said in the beginning, shifts us from top-down interventions to individual and community agency. As people living with HIV, myself included, self-care has been a part of our lives. It continues to be. It entails consistent responsibility for our health, demonstrated through taking the pill every day, dedicated adherence to our treatment, attendance to clinic appointments, and meeting those appointments when we should have them, and safeguarding our overall well-being despite systemic barriers. For many individuals confronting diverse health challenges, it signifies assuming charge of one's health when clinics are distant, stigma persists, and poverty compels many of us to have difficult choices between basic needs and essential medicines, sometimes for opportunistic infections. We now stand at a very, very pivotal point. The Global AIDS Strategy offers a historic opportunity to embrace self-care as the foundation for genuine transformation, as Sarah has just told us. It, in my view, is beyond just policy. It also serves as a pathway for innovation, for advancing differentiated service delivery that has been critical to keeping people living with HIV on treatment and staying alive. Through optimized treatment, prevention, and point-of-care diagnostics, we empower informed decision-making for our health. So ideally, investing in self-care strengthens health systems. I feel like this vision rests on three essential pillars. One, and most significant, is health literacy. Clear, timely, stigma-free information, recognizing that people, when informed about their health, can make the decisions that are needed for them. A good example has been the U equals U movement, where people living with HIV are currently educating ourselves on the benefits of HIV science. When a person living with HIV adheres to their treatment and are virally suppressed, then they cannot pass this virus. This message has significantly, data shows us, improved testing, improved adherence, viral suppression, and of course, has in its way helped to drive down HIV new infections. But information is not enough. We need practical tools, self-testing tools, self-screening for pregnancies, for HIV, for other diseases, PrEP, take-home prevention options that do not require us to be at the facility all the time, dual or multiplex diagnostics that help us address more than one disease at a time. These convert service availability into genuine access. And third, and most importantly, an enabling environment, freedom from shame, reduced wait times or other challenges that happen at facility level, integrated mental health support that is needed, affordable nutrition, and most importantly, equitable financing that eliminates this tension between survival and treatment. For UHC to happen and happen effectively, we cannot leave people behind because of costs to healthcare. These three pillars elevate self-care from personal practice, and they are really essential. I just want to pause here and share that GNP Plus did ask over 1,800 people participated in a survey that brought us the report, People Living with HIV, Minimum Requirements for Integrated HIV Services. It offers vital guidance right now based from people living with HIV and what they feel is needed, emphasizing transformative participation, context-specific models that place people living with HIV and those impacted by HIV at the center of decision-making. But we are not starting from scratch. I am excited to today join the Self-Care Trailblazers group, but I have been speaking about self-care for a couple of years now and was also involved in other discussions. The WHO has recognizes self-care interventions as critical to advancing primary healthcare, and Sarah shared the guidelines and the specific definition, and it leaves no one behind. The guidelines for self-care by WHO are supported by implementation examples that I have seen: Zambia, Kenya, Uruguay, Uganda, Morocco, others that I may not mention, demonstrate how country leadership and interventions driven towards UHC that reinforce primary health systems, make them resilient, and promote health equity for all. While it is also an opportunity for inspiring future innovation, policy development, and scale-up research. Colleagues, the HIV response has already showed us what is possible. As Hajot was speaking at the start, over 20 years ago, treatment was scarce for many of us, and palliative care was a big part of our HIV service delivery model. As community health workers at the time, actually, in my office, it didn't matter what role you had. You were assigned 2 houses and you made sure to go to those houses to provide care as a community health worker, even if you are an accountant or a programmer. When people living with HIV are fully included in our own health journeys, our individual actions ripple outwards, impact families, communities, and entire populations. These proven lessons build on an incredible foundation of community leadership must now propel us forward. Let this 20 person-centered care, for which self-care is a very big foundation of, and agency by anchoring strategy in self-care and community leadership. By doing so, we move people, everyone, from being passive recipients of interventions in health to visionary architects of health equity. And because I come from the HIV field, this is how we will end AIDS and achieve HIV